Okay. We're just about ready. So, hi, welcome everybody. Thank you for being here with us tonight. And thank you so much to our three speakers who are joining us here. It's truly a remarkable, scary, intense time. And even when we're just gathering to learn more together and learn from experts in our very own JVP family, it's just a wonderful thing to actually just be together and see each other's faces, since we're all so isolated from one another. So I'm grateful for that, even if some of the information we're going to hear tonight is difficult to take in. So I want to take a minute to just introduce the three people we have here sharing their wisdom with us tonight. So I'm going to share their little mini biographies, and then we'll jump right in with some presentations, and at the end, hopefully, we'll have plenty of time for Q&A. So the first person we're going to hear from tonight is Dr. Rachel Rubin, who's a senior medical officer with the Cook County Department of Health, and her areas of responsibility within the health department include oversight for the communicable diseases and environmental health services units. She also has been a participating internist for over 30 years with a focus on outpatient HIV care, and a specialist in occupational and environmental medicine as well as public health. She also has worked in Mozambique for 2 years as a public health specialist and district medical chief. Her interests include addressing health inequities in communities and workplaces, and building collaborative relationships with community-based organizations and other groups to build healthier communities free of discrimination and racism. She has her MD from Rush Medical College and her MPH from the University of Illinois at Chicago School of Public Health. So thank you so much, Rachel, for being here. And we'll shoot things over to you here in just a minute. After Rachel, we're going to hear from Dr. Alice Rothschild.
No, Peter's next.
Oh, sorry, you're right. Dr. Peter Sporn will be after Dr. Rubin, who's a professor of medicine in the Division of Pulmonary and Critical Care Medicine at Northwestern University Feinberg School of Medicine in Chicago, Illinois. He's also on staff at the Jesse Brown Veterans Affairs Medical Center in Chicago. And he's been active in the struggle for Palestinian health and human rights for many years, and is a founding member of the Jewish Voice for Peace Health Advisory Council. And then finally, we'll hear from Dr. Alice Rothschild, who's a physician, author, and filmmaker who's focused her interest in human rights and social justice on the Israel-Palestine conflict since 1997. She practiced OBGYN for almost 40 years. Until her retirement, she served as assistant professor of obstetrics and gynecology at Harvard Medical School, and as a fellow in the American College of Obstetrics and Gynecology. She writes lectures widely, is the author of Broken Promises, Broken Dreams, Stories of Jewish and Palestinian Trauma and Resilience, On the Brink, Israel and Palestine on the Eve of the 2014 Gaza Invasion, and Condition Critical, Life and Death in Israel-Palestine. She's contributed to a number of anthologies, the most recent being Reclaiming Judaism from Zionism, Stories of Personal Transformation. And you can find her website at alicerothschild.com, which we can share in the chat box as well. So clearly we have three abundantly experienced and brilliant speakers here tonight. Uh-oh, gotta mute some people, sorry. Abundantly experienced and expert, some wonderful experts here. So I'm so grateful to the three of you. And let's jump in. And if you don't mind, maybe just quickly just introduce yourself again, to say your name and where you're from, just because people will have a hard time keeping it straight since it's not in front of them. So let's go to you, Rachel, and I'll pull up your slides here in just 1 second.
Okay, so I guess the slides will be coming up momentarily. And as mentioned before, here we go. I'm Rachel Rubin, and my current position is Senior Medical Officer with the Cook County Department of Public Health. And Cook County is one of the largest counties in the United States. It basically encompasses the city of Chicago and all of the Collier County collars suburbs. My area of jurisdiction in my health department is all of the suburbs. The city has their own health department. The city has about 2.5 million people. We have about 2.3 million people with about 700 square miles to cover. So being a public health officer, my job has been basically taken over by coronavirus. I've been living and hopefully not breathing coronavirus since the very beginning, because the suburban area of Chicago was hit very in the beginning, right after, I think we were in the first 5 cases in the United States. We had a pair of cases in our jurisdiction, and things have just continued to escalate and mushroom. And I can't even tell you, everything else has been put aside, and this is what I and my colleagues have been doing valiantly. So what I wanted to do today was very quickly give an overview of what coronavirus is, and show a little bit about its, next slide. So showing a little bit about sort of information on the virus, how widespread it is, at least as of 48 hours ago when I sent these slides in. Things have continued to escalate. And what we are now is in mitigation phase. We are no longer trying to contain it or trying to stop it from spreading. It's really mitigating its effects, and to touch briefly on some equity issues, which I think is our paramount importance, and Peter will talk about that as well. So next slide. So what is SARS-CoV-2, or what is the coronavirus that we're talking about? So this particular kind of coronavirus, it's a new coronavirus. There have been coronaviruses that have been around for a long time, and probably most of us have been infected with the coronavirus, and it's just been presenting as a bad cold. But this is a new novel coronavirus that has now been called SARS-CoV-2, because SARS-CoV-1 or SARS-CoV was what we heard about. I think it was 2002. There was a SARS outbreak in China that also was worldwide spread, but nothing like this. It didn't hit the United States especially hard, but also originated in China. And so now it's a very similar virus. And so it's called SARS-CoV for coronavirus 2. And so that's the name of the virus. And the disease that it's called, that it causes, which is what we've been hearing in the news all the time, is COVID-19, which is coronavirus disease, 19 standing for 2019, because it was first announced in China in late December. Other diseases include the SARS-CoV as well as MERS-CoV, which was the Middle East Respiratory Syndrome. And SARS is, I guess, South Asia Respiratory Syndrome. And coronaviruses are common. And what's interesting about coronaviruses is they are what we call zoonotic infections, which mean they are infections that are transmitted from animals to humans. And we think that this particular SARS or coronavirus isn't, especially, but specifically this one, we think are probably originally was incubated and infected bats. And then bats would bite cats, not your house cats, but big cats, cattle and camels and other kinds of animals. And eventually at some point it jumped to human beings. And it may very well have made this jump a while back, but it first started to propagate significantly in humans over probably November and December of this year. Next slide. So, sorry, I gotta move this over so I can see the slide. There we go. So COVID-19 is the disease caused by SARS-CoV-2, and it's currently, it was upgraded to a pandemic late last week. So we are now calling it a pandemic. And the difference between an epidemic means it's quite widespread, possibly multiple countries, certainly within a particular country or region. Pandemic is when we're beginning to see it in a very large, widespread area. And in this instance, it's all over the world. We now have it on all continents. There have been over 500 countries that have reported the disease. And there have been travel restrictions and bans currently in place that many of you are aware of and may even have been affected by. So the bottom line is that follow your local authorities' guidance on mitigation efforts. I'm not saying that all of that guidance is sufficient, but I wouldn't say that it's wrong. And I do think that the public health workforce, generally speaking, is made up of some really dedicated, smart people that are not here to do the work to further an agenda of the administration. And there's been lots of criticism of our federal administration on their approach to this because they weren't listening to public health authorities. So, next slide. So this is a situation report, somewhat fine print, but this is what comes out every day from the World Health Organization. This is the one that came out on the 16th. And it comes out sort of mid or late in the day. And you can see here on the right, the globally 167,000 confirmed cases. Now I heard today over 180,000 cases. So it's jumped almost 20,000 in a matter of 2 days. I think that the death rate is, I don't know, 7,000 to 8,000 by now. China had started to see a decrease in their number of new cases that they were seeing, but now they're starting to see an uptick again. It's almost sort of like a second wave that they say is because of international travelers. I don't know if these are Chinese nationals who are returning home or other kinds of visitors that have been in China more recently and have brought the disease with them from Europe and other parts of the world where the incidence of disease have been climbing. And so that's unfortunate because China was really finally starting to see a dip. And you can go onto the WHO, the World Health Organization web pages every day if you want to look at these sort of chilling statistics. Next slide, please. Sorry. So this is the distribution of COVID as of 2 days ago or 2.5 days ago, and you can see it's everywhere. It's on all continents. I think the only places being spared right now is the North Pole, but you really do see it everywhere. And the bigger the dot, the more people there are that we have diagnosed. So you'll see the United States has a pretty big dot, but it's not as big as in China and other parts of Asia. Next slide. So here's what things look like again as of on the 17th of March. All states reporting cases of COVID-19 to the Centers for Disease Control and Prevention. And you can see that it's every single state, 50 states now have at least some cases. Looks like Alaska doesn't have very many, between 1 to 5 cases. In Illinois, we had, which is my state, we had reported today, I just looked it up, over, I think, close to 400 cases in Illinois, over 250 in the Chicago area. So that includes the city as well as the suburbs of Chicago. The Seattle area, the last I saw, had over 400, 500 cases, something like that, maybe even more by today. Next slide. So it's everywhere. And this is what we call an epi curve. And this is where you can see how it is increasing. It looks like the last few days that it's been dipping down, but that's not true. If you read the end note here, it says illnesses that began during this time, the last couple of 4 or 5 days, may not yet be reported. And as one can probably look, if I were to pull this curve up from today or what will look like tomorrow, it'll look like there's sort of like this exponential increase. And that's because we are finally being able to do more testing. Not enough, but we've been able to do more testing because certain commercial labs and hospital labs have gone online. So more people are being tested. Therefore, more people are being diagnosed who probably ordinarily wouldn't necessarily have been tested. So we would not have known that they've been positive. And we are reaching the point now where we are not telling everybody who feels sick to call their doctor, who can then arrange for testing in a safe manner. We're saying that if you have a mild illness, stay home. Don't leave home until you're better, and not go out and self-quarantine, because we do not have the resources to test everybody. We do not have the ability to make sure that if you do come into a facility that everything can be set up in a safe manner. so that you won't be infecting other people if indeed you do have COVID-19. So stay home if you're sick, unless you're very ill and need to be in a hospital. And that's what we're turning to, at least in my jurisdiction in Chicago area, and in other parts of the country that's beginning to be the case as well, certainly in New York and Seattle and Southern California. Next slide. So these are what we're doing now, mitigation strategies. And these include, if you feel sick, stay home, don't go to work, contact your medical provider. If your children are sick, keep them at home. I shouldn't say don't send them to school, because in many places schools have been closed. In multiple states now, the schools have been shut down, and they are attempting to do distance learning for those schools that can accommodate that. Universities, almost all universities have been shut down, and our young adult children are coming home to be with us and to do distance learning. If someone in your household is tested positive, it's suggested that you keep the entire household at home. It doesn't mean that everybody in your house has to be stuck in their private bedroom, but if somebody is sick, try to put them in a room by themselves. And you understand that this can be very difficult for a family of 5 that only have 2 or 3 bedrooms, because the children in one bedroom, the parents in the others, and you don't have, and then maybe your grandparents are living with you, etc. And so there can be very, very difficult situations about trying to self-isolate in home, which means when you're positive, putting yourself away from everybody else in the household, like being behind a closed door, not using the bathroom at the same time, wearing a mask if you have to leave your room, and then isolate, and then quarantine, which is where you are just isolated, not isolated, you're just kept at home. You're just restricted to your home. And that's what we suggest for the close contacts until you might get symptoms, and then you can assume that you have the illness, but at least you won't be infecting the community. If you're an older person, stay home and away from other people. My parents were in their early 90s, live in a independent living senior building, assisted living level as well. And there are no visits. I cannot see my parents. I mean, I can see them virtually if I can get them to learn how to use their smartphone camera. But basically, I can only talk to them. I cannot see them. And if you're, because people are being locked down, because seniors especially are extremely vulnerable to getting severe complications from COVID-19. And if the same thing goes if you're a person with a serious underlying health condition, especially lung or heart disease, or other diseases even like diabetes, where your immune system can be affected. So that means you're more likely to get even if you're not necessarily always more likely to get the disease, but you're more likely to get a serious complication from the disease. So to get a pneumonia or to get a respiratory failure and be on ventilator, etc. And of course, distance yourself. What we're saying by distancing also means staying 6 feet away from somebody if you can. Next slide. And this talks about, this is a CDC slide that lists a little bit more what we mean about what you can do. So if you can stay home from work and school, please do so. If you work in a critical infrastructure industry, which basically means first responders, healthcare, working on developing pharmaceuticals, working in the food supply, I mean, these are many, many of us. It also doesn't talk about all the people that cannot avoid going to work, because if they don't get to work, they don't get paid. If they don't get paid, they don't have money for food, etc. Avoid social gatherings. Now at most restaurants, I'm here in Washington, D.C. at the moment, and the restaurants are all shut except for carryout. Same thing in the state of Illinois, throughout the state of Illinois, not just Chicago. So nobody can be in a congregate setting. You can't sit down and have a meal in a restaurant. Avoid discretionary travel, shopping trips, etc. Don't visit nursing homes or retirement and long-term care facilities unless to provide critical assistance. That's really important. And what can we do individually? Don't touch my face, touch your face, which I'm sure I've done a couple of times during this talk. Wash your hands, and it's got to be for 20 seconds. And 20 seconds is a long time. I mean, if you think about it, I demonstrated this the other day when I was talking to my staff, and I was sitting there rolling my hands for 20 seconds, and people were looking at me and they started to laugh because they realized how long it really takes to wash your hands for 20 seconds. But really, wash your hands for 20 seconds. Avoid touching your face, sneeze or cough into a tissue or into the, inside of your elbow, your sleeve. Disinfect frequently with hand sanitizer, wipes, all of that. Next slide. So we need to take action now. We need to protect each other during the pandemic. And this was published from The Nation by Nation Action, which is sort of their, I guess, advocacy arm of The Nation magazine. And this was published on the 15th, so just a few days ago. And they give, in that article, you can Google it, just go to Nation Action, about various things that we can do to support the most vulnerable in our society that do not have the resources that many of us others have. So the low income, incarcerated, homeless, undocumented are confronting the harshest effects. Also the xenophobia that we're seeing, Asian people are being targeted, and this is horrendous, as I'm sure you all agree. And this quote from the New York Times, The Interceptor, published a couple days ago, public health isn't just about your own personal health, it's about the health of the public at large. If there's one person who can't get treatment, that person is posing a risk to everybody. And so that means not one person not getting treatment. So who is the person who's least likely to be able to get treatment? It's all of those people listed above, as well as other disenfranchised groups in our society. So next slide. Final slide of my presentation. So we need an equity-oriented solution to COVID-19, not stigma, discrimination, and fear. So I'll pass it on. Thank you.
Thank you so much. This is really, really helpful information, and really appreciate that. I'm gonna move us swiftly along, and we'll hopefully have plenty of time at the end to come back. I'm jotting down questions I have for you, Rachel, so hopefully we'll have time to get to those and others. Go ahead, Peter. Do you mind just remind people sort of who you are and where you are really quickly, and then jump right in.
Hello, everyone, and thank you for joining in this webinar. So I'm Peter Sporn. I'm a pulmonary and critical care physician. I'm a faculty member at the Northwestern University Feinberg School of Medicine. I've been practicing at Northwestern and working as a member of the faculty for over 25 years. I will tell you a little bit about my specialty. My specialty is linked specialty, both pulmonary medicine, that is, I'm a respiratory disease physician, and I'm also a critical care physician. I work in the intensive care unit at my hospital. And pulmonary critical care physicians, generally speaking, are the largest group of physicians who work in intensive care units in the United States. And a large proportion of physicians working in this dual specialty actually do both, take care of both patients with chronic respiratory illnesses, and I do that, and also work part of the time in intensive care units. And to set up the stage for how things work at my institution, I want to explain to you that we have in my division, that is the Division of Pulmonary and Critical Care Medicine, over 30 physicians who are full-time members of our faculty. And as in most medical schools, all of us, all of the 30 plus physicians in my group have a variety of responsibilities, and those include taking care of patients who are seen in the clinic, outpatients with respiratory disease, taking care of patients in the hospital who are not critically ill with pulmonary disease, and then staffing our intensive care units. In addition, we have responsibility for educating our medical students and our residents and our fellows, that is advanced subspecialty trainees, and we have research programs, and I have involvement in all of those. And so while we have over 30 physicians, we're not all doing clinical work full time under normal circumstances. However, at this time, that is changing because we're faced with an unprecedented clinical crisis, really. And just within the past 10 days or so, all of our responsibilities have changed because of the pandemic and what we're seeing. And so to tell you more specifically about the experience at my hospital, and I should say a little bit about my hospital. First of all, I work at Northwestern Memorial Hospital, and some of the time I work at our affiliated VA hospital. I'm not going to talk about the VA hospital right now. The hospital I work in, Northwestern Memorial Hospital, is actually the largest hospital in the state of Illinois. We have almost 900 adult beds. Our Associated Pediatric Hospital doesn't count in that number. They have a separate facility attached to the adult facility. So it's a very, very large hospital. We have over 125, under normal circumstances, over 125 intensive care unit beds. The medical intensive care unit, which is the part of the intensive care scheme that I work in, has, under normal circumstances, about 35 beds. We have expanded that in the current situation. As of 10 days ago, we didn't have any patients with COVID-19 yet in our intensive care unit. Right now, we have approximately 15 patients with respiratory failure, and we have others who are on the verge of that. And then outside the intensive care unit, we have dozens who have the illness but are not critically ill. This is a dramatic change just within the past 10 days, 10 to 14 days. We are one of the best resourced hospitals, both in terms of staffing and in terms of specialists and in terms of advanced equipment and in terms of the numbers of, or the proportion of beds devoted to intensive care that you'll find anywhere. And we are taxed right now, although we are fully able to handle what we have today. But I anticipate that if the numbers that we're seeing now double, and I anticipate that they will within the next 1 to 2 weeks, we will actually be at a point where we're exceeding our own capacity, which is probably greater than the capacity of most other hospitals in the United States, the exceptions being other university hospitals like my own, and certainly in relation to what's available throughout much of the rest of the world, particularly the global south and many, many other places. But I would like to emphasize that while we are doing all that we can and will continue to do that, there are, and you know, everybody has heard over and over again about the populations that are most vulnerable. We've all heard that people who are over the age of 60, or particularly over the age of 70, over the age of 80, the vulnerability goes up and up as you get to these older age groups. People who have chronic lung disease, people who have chronic heart conditions, people who are immunosuppressed as a result of treatment for other conditions, and people who have cancer on chemotherapy. All of these are the vulnerable populations that we've heard about over and over again in the media. What the media has not emphasized to the same degree is other vulnerable populations. And I would point out that people who are incarcerated, who are in close quarters, who often are forced to exist in less than fully sanitary conditions, people who are homeless, who either have to go to shelters or don't go to shelters and live outside, are extremely vulnerable. Immigrants under detention are extremely vulnerable. Migrant workers, migrant farm workers who generally live in very crowded and often not sanitary conditions are extremely vulnerable. And all of these groups of people that I'm mentioning now are receiving very little attention. And these are also individuals who, within our own midst, we're not talking about the other parts of the world where the resources are much less available. But these populations, I would emphasize, have little ability to access quality care and the appropriate medical resources for the epidemic, the pandemic that we are now facing. Alice is going to talk next about what's happening in Palestine, but I would emphasize that we have a crisis looming right in our own midst here in the United States. And so I think I'm going to leave it there. I'll save time for people to ask specific questions later. So thanks.
Thank you so much. I see some questions are coming in the chat. I'm collecting them. I'm taking notes. So you're not going to be forgotten, and we'll try our best to get to all of them. So with that, let's move to you, Allison, or Alice, sorry.
So first slide.
Great. Give me 1 second to pull.
Okay. So I should just say, as I prepared the survey of what's going on in Israel-Palestine, it was such a moving target, and the numbers kept changing every couple of hours. So my slides are very bare because I wanted to give you up-to-date numbers. So I'm gonna, is there going to be a slide? Okay, so I'm going to start with the impact of COVID-19 on Israel-Palestine. Next slide. And the first place I'm going to look at is Israel. So in terms of medically what's going on there, 2 days ago, there were 324 documented cases. Today, there are 677. So you can see that they're in the upswing of the virus. And Israel has a first world healthcare system, so they're having a lot of the same issues and strengths that we have in the United States. They do have testing available. They're running about 3,000 tests per day. They did try to have drive-through facilities, but then they had to close them due to lack of equipment. So equipment is an issue. There are currently massive closures and quarantines of all cultural and recreational establishments, schools, universities, beaches, and indoor gatherings of over 10 people have been banned. A state of emergency was declared on the 14th, and on the 17th, a state of full home quarantine with fines of up to 5,000 shekels for violation. They also have several nursing homes that are under isolation, and they have set up 3 quarantine centers. Now, foreigners are not allowed into the country unless they can do a 14-day self-quarantine, and all Israelis returning internationally have to go into a 2 to 3 week isolation, self-isolation, which currently is about 80,000 people. This has all had a huge economic impact. Tourism is way down. There have been massive cutbacks and layoffs. 70% of workers in the private industry have been sent home, and 110,000 have been fired or on unpaid leave. All combat soldiers, as well as those serving in training bases, are required to stay on their bases and are not allowed to travel. And they've called up 2,500 reserves to help with the crisis. They've also closed down public transportation from 8 p.m. until the morning and on weekends, and there have been massive cutbacks in transportation services in general. So the country is really feeling the impact. There are several big concerns. There were a large number of Israelis who returned from the AIPAC conference in early March, and they did not self-quarantine. And then there were 3 cases from the AIPAC conference. So they are a possible source of infection. Another big issue that is in the country is that the Attorney General approved the use of cyber measures to track the phones of coronavirus patients in Israel and the West Bank by the Israeli police. They used geolocation data, and this was originally put into effect for combating terrorism, quote unquote. But now there's a huge tumult about the privacy concerns, and it looks like this whole program may be put under Knesset oversight, but there's a huge amount of monitoring of the population. Another thing, which is a cultural thing, is that the ultra-Orthodox leaders ordered the Haredi schools and yeshivas to stay open. They said canceling Torah study was more dangerous than the coronavirus. They have been now convinced that they should not study in groups of more than 10. Another part of the political problem is the updates, the social media, the apps were all being done in Hebrew, and the translations into Arabic were delayed and often inaccurate. Another big issue, which is also an issue in the US, is that prison authorities have not taken adequate measures to protect the health of some 5,000 Palestinians who are held in Israeli prisons and detention centers. And these folks have lack of hygiene products, they're packed into dirty cells. There've already been 4 cases in the prisons in Ashkelon and Megiddo, 5 cases, excuse me, and several more suspected in other detention centers. And so that's a very, population that is very at risk. And the whole system has been shut down, so visitors and lawyers are now barred from the prisons. Now, when we looked in the occupied territories, the risk assessment is that this is a very high-risk area, And the medical and public health response is being, oh, new slide, is being coordinated by the World Health Organization. So the other thing to think about is that many Palestinian communities are already sort of quarantined by Israel for political, not medical reasons, which may be somewhat protective, but an outbreak of the coronavirus in these communities, especially the ones that are cut off from proper health care and well-equipped medical facilities, will prove disastrous. And on top of that, Ramadan is coming April 23rd. We have no idea what the impact of fasting is on the immune system, on how people will react and their resilience. So if we look at the focus on the West Bank, next slide, there have been 47, in Jerusalem, one sec, go back to Jerusalem. I don't have data separate from East Jerusalem because Israel counts it as part of Israel, but the Al-Aqsa Mosque has been closed, which was a very big deal. Next slide. In the West Bank, in terms of the medical update, there have been 47 cases as of today. The coronavirus was brought to Palestine by Greek tourists and a South Korean delegation who traveled all over and then subsequently tested positive. In terms of closures and quarantines, and again, this is all happening under the closures of occupation, the Palestinian Ministry of Health has declared a state of emergency on all hospitals under their jurisdiction in the West Bank. There are quarantine and treatment centers that are being established, and there are currently almost 4,000 people under quarantine. The Ministry of Health has developed a new COVID-19 dashboard in Arabic to track cases, and there are central operations areas in the Prime Minister's office to coordinate activities, media, and notify the public and keep them updated. Schools and public gatherings are done. Public gatherings of more than 100, and schools are closed, and this includes mosques and churches. This is all having a huge economic impact. It's important to remember that the Israelis still control the area, so on the 10th, they let Israeli settlers dance drunkenly through Hebron for the yearly Purim celebration, while all the Palestinians were kept under lockdown, even though this was forbidden according to the Palestinian Authority. And then on the 12th, the Israeli army allowed a group of Jewish settlers into Sebastia, which is an archaeologic site, even though the PA had closed all the tourist sites. So there's this friction politically that goes on. The points of entry have checks for travelers and isolation wards and health facilities that have been established. Travel through Jordan, you can get into the West Bank if you have a West Bank or an East Jerusalem ID, or a UN or diplomatic passport only, and you cannot get from the West Bank into Jordan. That's completely closed. Now, the epicenter of the virus is in Bethlehem, and they have, and then there are 2 cases in Tulkarm, a case in Ramallah, and a case in Nablus. So Bethlehem and the surrounding towns and Tulkarm are currently under closure. But other things are happening. The governor of the Ramallah district announced that all restaurants, cafes, gyms, and sports facilities will be closed indefinitely, and they have suspended all indoor and outdoor public gatherings. In Hebron, health workers were deployed across the city to fumigate public areas like municipal facilities, public parks, bus and taxi stations, and mosques. All the restaurants in Jenin were closed, and similar measures have been employed in Jericho and in East Jerusalem. In terms of the donor response, Qatar has donated $10 million and Kuwait has donated $5.5 million. Now, there's some big issues, obviously. One is that Palestinians who live in Area C, this region is entirely under the control of the Israeli army, and they have little interest in the welfare of the Palestinian inhabitants there, so we have no idea what protections they will be offered. In terms of the workers going into Israel, there are currently 120,000 Palestinians employed within 48 Israel and in the settlements, along with tens of thousands who are living and working in Israel illegally. So they pose a risk to Israel going from the West Bank to Israel, but mostly they pose a risk from the West Bank going to Israel, which has many more cases. So what's recently happened is that the government has announced that these folks have 3 days to figure out sleeping arrangements in Israel through their employer. And if they can figure it out, then they will stay in Israel indefinitely and not be allowed to cross over. And this only applies to construction workers, agricultural workers, and for people who are less than 50. So this is going to have a huge personal impact for families. Do they choose staying with their families or making money? And then the economic impact. The other thing is that they still have to go through checkpoints, and checkpoints are a source of severe delays and crowding and a place where infection could spread rapidly. The other thing is that incursions by the IDF, the Israeli Defense Force, and settler attacks continue unabated. So that's a population, again, that is at possible delivering virus to the Palestinians. Now, the World Health Organization has delivered kits, test kits to the Ministry of Health in Ramallah, and they promise more. And Israel has delivered some supplies and testing, but the numbers are grossly inadequate. In addition, the Ministry of Health lacks equipment and facilities. So for instance, all the patients who currently have coronavirus are being treated in hotels, not in hospitals. Next slide. Now, if we think about Gaza, first of all, just think about the kind of measures that are being recommended to prevent the spread of the virus and how possible it would be in a place like Gaza. So you're supposed to wash your hands with clean water. Doesn't exist in Gaza. You're supposed to avoid close contact with symptomatic people. This is the most crowded place in the universe. You're supposed to avoid direct and unprotected contact with live animals. There are a ton of animals there. This is not going to be possible once the virus hits there. Now, fortunately, there have been no reported cases as of today. Now, in terms of closures and quarantines, travel is basically closed down. Only urgent humanitarian cases are allowed out, but barely, because that's the rules anyway. But you can imagine that if a coronavirus outbreak in Gaza occurs, the likelihood of exit permits for medical care being rejected is very high, given the whole politics and the history, particularly if Israel is struggling with its own outbreak. Now, the World Health Organization has set up quarantine areas in Rafah, which is the crossover to Egypt. And this quarantine area has 50 rooms. If you go through Erez, you have to go home and self-quarantine. There are also 6,000 Gazan residents, who are mostly laborers, who had valid permits to work in Israel, and they are no longer able to do that. It's important to remember that the average Gazan earns 6 times as much in Israel as they do in Gaza. So this has both an infectious disease and an economic impact. Now, in terms of closures, the schools and the universities are all closed. In terms of medical support, the World Health Organization is holding donor briefings, and donors are stepping up to provide resources and identify gaps. The World Health Organization, UNICEF, and the Ministry of Health, as well as the private sector, have set up a task force to develop communication strategies and combat misinformation. And the World Health Organization has delivered test kits to the Ministry of Health in Gaza. And just to give you an example of the inadequate state of affairs, Israel has delivered 200 test kits to Gaza. So the numbers are just grossly inadequate. Now, there are plans to establish a medical checkpoint at Erez. They are building a field hospital at Rafah. So the Erez is in the north, Rafah is in the south. And this field hospital will have 36 beds with 6 ICU beds. But all the reports that I read would say things like, substantial capacity gaps need to be addressed. In other words, the healthcare system is already on its knees, and they're going to need a lot to even rev up to be able to deal with this. So this means that procurement of essential medical supplies and equipment needs to happen in the face of chronic shortages of drugs and disposables, and a lack of mental health and psychosocial supports. Now, in terms of the issues, the list is very, very long, and I'll just go through some of the big ones. There's an inadequate supply of sanitizer gel and face masks. 97% of the tap water in the strip is undrinkable, and much of it is unclean, so you wouldn't want to wash your hands with it in the first place. The waste disposal services are poor due to insufficient supplies of electricity and inadequate infrastructure due to previous bombings and wars and the blockade. There's a severe deficit in medical supplies. Currently, there are 100 pieces of protective gear for health professionals across the strip. These professionals are also poorly paid, they're overworked, they're right on the edge of falling apart because of the protracted health crisis due to the thousands of injuries from the Great March of Return. And this is all compounded by the 13-year blockade and conflict with Israel. The power supply is unreliable, there are constant fuel shortages, and if you look at other diseases like measles and other highly contagious infectious diseases, they're all coming back to Gaza because of the environmental situation. And waterborne diseases are also spreading at an alarming rate, which gives you a sense of how easily infectious disease can travel. So this is the baseline. This is the horrifying normality. And it would be a potential catastrophe if you combine that with a COVID-19 outbreak. So even a small outbreak, which it won't be small, would put an impossible strain on an already struggling system. Gaza is densely populated. The disease would spread quickly. It's more like, you got to think of it more like how a prison would react in terms of a disease outbreak. And then you have to look at the fact that there is considerable economic issues in Gaza. The unemployment rate is more than 50%, and there's a lack of supplies due to restrictions on the import of goods. So it would be impossible for families to go, stock up and go stay home because they can't get essential items and medications. And those obviously with existing health concerns would be particularly vulnerable to disease. Now, if you look at the general health of many people in Gaza, it's been declining due to the severe healthcare deficit, the environmental toxins, et cetera, and the low standard of living. So this population is uniquely susceptible to how it's going to be infected and how it's going to react to infection. It is also questionable whether the general population in Gaza would have any access to testing kits if they're suspected of contracting the disease, and even more questionable whether they would receive adequate medical care if they actually become infected. There have been 3 quarantine sites set up in the south. They're setting them up in schools, but an analysis of the conditions in the schools reveals that there are 10 beds per room. Already that's not okay. The hygiene is poor and the care would be poor. So the World Health Organization has warned that if there are a large number of COVID-19 cases in Gaza, this would contribute to the total collapse of the Gazan health system. Now, it's interesting, even given that disastrous statement, that the focal point of the coronavirus is outside the Strip. So paradoxically, the relative separation of Gaza from the rest of the world is protecting it. But this is a temporary thing. There will likely be a patient zero in the future, whether it's one of the laborers that were working in Israel, someone in an NGO or an aid organization, or the 605 people that recently came back from a pilgrimage to Saudi Arabia. So people know this. So there's already a sense of growing panic within the population. Now, if the virus spreads into the Strip, which it will, Israel will have difficulty shirking responsibility for it. The international community has never accepted Israel's argument that it stopped being responsible for Gaza after the disengagement in 2005. And the Palestinian Authority, which is technically responsible for the Strip since the Oslo Accords, hasn't been present since it was expelled in 2007. So I think you have to imagine what will happen if tens of thousands of Palestinians march to the fence demanding that Israel assist with the humanitarian catastrophe in the Strip. So the coronavirus is really bringing to the surface unsettled problems regarding Israel's relationship to Gaza Strip that have never been resolved over the years. And we all know that the virus has no boundaries. So I think when you think about this, the successful preparedness and management of a pandemic and treatment of the disease has to be based on an end of the siege of Gaza. Thank you.
Thank you so much. This is really difficult to hear, but I think incredibly important for all of us. And I'm so grateful. I've been seeing questions come in, so let's get to them. We have about 10 minutes. We'll do what we can. One came in while you were speaking, Alice. I just want to start there because you were just talking about this. But Allison was saying that, said, I was on a call the other day convened by a very different type of organization, but working in Israel-Palestine space, where various nonprofits were talking in terms of, quote, because Corona doesn't discriminate between Israelis and Palestinians, organizations shouldn't think about normalization when, quote, working together. So how should we be thinking responsibly about normalization in this situation?
Well, I think that normalization is a political conversation. Dealing with a medical catastrophe and a pandemic is a whole different conversation. And right now, we need to marshal whatever forces there are in the universe to provide testing, care, technical support, whatever is needed to minimize the horrific damage that's going to happen. But it's going to highlight the impact of siege. And you know, I just think it's a different conversation. I don't know how other people feel about that. I mean, the reason it's so bad is because of the siege and the blockade and the occupation, and it's really bringing that all to the fore. And I don't think that's an argument for normalization. I think it's an argument for everybody trying to take care of each other.
Right. Great. So there was another question about in New York, apparently they're giving out compassionate care meds when people become very sick. I'm not sure exactly what compassionate care meds are, but what do you all think about that? And that can be for any of the three of you. If compassionate,
I'll make a comment about that. I'm not sure precisely what circumstance is being referred to, but we do, when patients are at the end of life, provide medicines to ease the pain and suffering that comes with the dying process. And so those types, the medicines we use under those circumstances are referred to as compassionate care medicines. But I think the bigger issue, perhaps in relation to the COVID-19 pandemic, is that when the number of people who are ill exceeds the capacity to provide standard care, we will face a situation, and it could happen soon here in the US, like has been well documented in China and in Italy up to this time, where a choice has to be made between actually providing care that has a chance of curing the illness to one person and not doing so in the case of another person. And under those circumstances, I suppose one could talk about whether one is going to give medicines to ease pain and suffering, the struggle to breathe in the face of respiratory failure, to patients who are not able to get on a ventilator because there aren't any more, for example. But this is the situation that I fear we will face in the United States, something that, to my knowledge, has never really happened before. Certainly not in my career, which is actually a fairly long career at this point. So I think that's the issue. And, you know, as I mentioned earlier, there are segments of the population that won't even necessarily get to a hospital where the decision has to, the decision would be made whether to put the person on the ventilator or provide the type of advanced care that would be appropriate under those circumstances. The populations I mentioned before, people who are incarcerated, people in immigration detention facilities, people who are homeless, people who are migrant farm workers, or people perhaps who live in rural communities that are far from a sophisticated medical center. These people are all at great risk.
yeah, it looks like they clarified in the chat that they meant antiretrovirals and hydroquinone, and there was talk of using malaria meds and interferon. Now I'm reading through the.
Okay, I guess I misunderstood the question then. Well, there are certain medications that it has been proposed might be beneficial that might have beneficial effects in patients with COVID-19. None of the medicines that are being discussed have actually been proven to be effective in treating the disease, but we have the ability to provide certain types of medicines on what's called a compassionate use basis. And that means that the FDA will allow medicines to be provided to patients who are seriously ill or at risk of dying when there is no proof that the medications work. And that's a different standard that's applied under every other circumstance. And so, for example, in my intensive care unit now, we are using two of the medicines that were just mentioned. One is an antiviral medication called remdesivir, and the other is hydroxychloroquine. Two medications which has been suggested might be effective for coronavirus, but for which there really is no proof. So we are giving those medicines on a compassionate use basis. We don't know whether it's actually helpful.
Great. There was a question about how that choice gets made. You talked about if we get to that point where the choice is going to be made about who gets the ventilator, who gets the care, the life-saving care, and who doesn't. What are those choices made based off of?
Well, I'll say something again about that. That's a situation that's going to be very, very difficult to face, but one can easily imagine how all the biases and injustices that exist before we get to a crisis point like that will come into play. And certainly people who are disadvantaged are going to be likely to be on the short end of the stick when we're faced with those kinds of decisions in many places.
Oftentimes, those kinds of decisions are made on the basis of age, underlying conditions, likelihood of success, but it also is resource, ability to get resources and all that kind of stuff.
Yeah. There was a question that I had around, Rachel, when you were talking about sort of how widespread the disease is and how quickly it's moved. I was wondering about whether there are other viruses or diseases that have spread at similar rates, but that are just much more benign. I mean, is this something that is unprecedented in terms of its how widespread it is, or is it because of how widespread it is in combination with how severe it can get?
I think it's the latter. There are many diseases that are, basically endemic, as we say, just sort of in our environment throughout the world. There are certain, but they don't cause such severe illness except in maybe very unusual circumstances. And so the problem is that it's even the influenza is as widespread, if not more so than coronavirus or COVID-19. But we have vaccinations against influenza, and we do have medications that can lessen the severity of the disease. We do not have that for COVID-19. So that's what makes it especially harmful and difficult to handle.
Great. I see lots of questions pouring in right now, and we just have a minute left. So I'm just going to do one more, and then we'll wrap up, and then maybe we can figure out a way to continue to tap into your brilliance for JVP members. The question was about what response are you hoping to see from the federal government? And I guess the question could also be internationally, what response are you hoping to see from the international community as well? That could potentially stave off what your worst fears are with this.
I think at this point, I think that there's no way of staving off staving off the continued spread of the disease. I think that the federal government, however, needs to be much more proactive in making sure that the most vulnerable of individuals and the least resourced of our communities have resources and support for the ability to home isolate or home quarantine, the ability for communities to survive and individual families to maintain themselves in this situation, that the homeless, that the incarcerated are being taken care of. I heard today that the first case was diagnosed in an incarcerated population. It's probably not the first, but the first that we know of. And I can't imagine what it's going to be like in that prison. And they don't have the ability to, they might be able to isolate that one individual, but they don't have the ability to quarantine all of the individuals that may have been exposed to the case. It's a disaster waiting to happen. This is what we're seeing in our nursing homes now. And for our federal government to say, for President Trump to say he wants to push this response out to the states. I mean, the states and the local health authorities have been working tirelessly from day one, but we don't have the money and the resources that the federal government can push out to that level. And so he's saying, that that the federal government is not just a delivery service. Well, we can comment more on that offline, but clearly that's an inappropriate and entirely inadequate response, to say it politely.
And just thinking about Israel-Palestine, I think that while we are attending to our own communities and to the artists and businesses that are folding and all the things that are going on, we do need to keep yelling at our congresspeople about the situation in the West Bank and Gaza, particularly Gaza, because I think it's very much off the radar because of so much pain in our own country. The other thing is that Middle East Children's Alliance and the UN UNRWA have launched emergency fundraising drives. So if you want to personally give to something, Middle East Children's Alliance is trying to do what it can to mitigate some of the crisis that's going to happen. But I think this should fuel our anti-occupation, anti-siege work, because ultimately that's the only thing that's going to make this better.
Great. Any last words from you, Peter, or either of you, Rachel or Alice?
Well, I would just like to say that thank you to all the people who've signed on to listen to this. And I think it's important that we support one another. And I want everybody to pay attention, of course, to the common things that we've all been told, and take those recommendations seriously with regards to social distancing and hand hygiene, and keeping distance from anyone who might appear to be sick. So stay safe, everybody. We need you in this movement, and so we can't afford to lose a single one of our dedicated members and supporters.
Yeah, I can only second what Peter says and leave it at that.
Well, thank you. Thank you for all the work that you three are doing, and everybody here for showing up and asking great questions. Thank you again for taking the time. I hope you guys get some much needed rest and keep up the good fight.
Okay.
Thank you.
Thank you.
Thank you.